Hi, I'm Dr. Judd. I'm a urologist and a urologic oncologist at Duke University Medical Center in Durham, North Carolina. And my practice is mostly limited to men with prostate cancer, both early and advanced stage disease. So as a urologist, the thing that was most interesting about ARCHES is that it gives us a new important option for men with metastatic hormone-sensitive prostate cancer. And as a urologist, we see these men who have newly diagnosed metastatic disease, and it gives us a new opportunity to get more experience with Xtandi. So at Duke, I work in a multidisciplinary clinic with medical oncologists, radiation oncologists, and urologists. And me being a urologist, I had experience with Xtandi since 2012 when the drug got approved in advanced hormone refractory or castrate-resistant prostate cancer. But the ARCHES trial now gives me a better opportunity as a urologist to get more experience with this drug because it's now used in a disease state that is more common for me to see as a urologist. I'm the one that's seeing the men with newly diagnosed metastatic prostate cancer. And so now I feel comfortable using this oral option, which we've had experience with. I feel very comfortable using this in my patients with newly diagnosed metastatic prostate cancer. So all patients with metastatic prostate cancer benefit from Xtandi. We know that the drug is useful and improves radiographic progression-free survival in men who have low-volume metastatic disease and high-volume metastatic disease. We have other options for patients with metastatic prostate cancer, particularly chemotherapy, but chemotherapy has only shown a benefit in men with high-volume metastatic prostate cancer, whereas Xtandi has benefited patients who have many metastases all the way to patients who have potentially one site of metastasis. We have known since 1989 about the concept of combined androgen blockade in advanced prostate cancer. And that concept used some of the earlier generation agents such as flutamide, nilutamide, and bicalutamide to add to hormone therapy to treat men with advanced prostate cancer. Those were first generation agents which were not very potent. We now know with Xtandi, which is a second generation agent that has much more potency, that it provides a survival benefit and a radiographic survival benefit that the previous generation agents did not produce. So in my practice, when I have a patient with metastatic prostate cancer, I see no role for bicalutamide because we now know Xtandi has been proven survival benefit, proven radiographic progression-free survival benefit. So we should use these more modern, potent agents to treat our patients with metastatic prostate cancer. So already in the United States, we've had Xtandi approved for metastatic castrate-sensitive prostate cancer for about a year. And at least in my practice, I honestly have not written a prescription for bicalutamide in the last year, simply because the newer generation agents, such as Xtandi, have proven survival benefit, have proven radiographic progression-free survival benefit, whereas the use of the earlier agents, such as bicalutamide, the survival benefit was always suspect. It was never completely proven, and therefore, now I would use an agent that's clearly proven to extend my patient's survival and extend my patient's radiographic progression-free survival. So when I have a patient who presents with newly diagnosed metastatic hormone-sensitive prostate cancer, and that patient falls into the low volume disease category, I would offer those patients Xtandi because we know from the ARCHES trial that Xtandi improved radiographic progression-free survival for men who had both low volume and high volume metastatic disease. So Xtandi becomes the agent of choice for men with low volume metastatic castrate-sensitive prostate cancer. So when I'm faced with a patient with newly diagnosed hormone-sensitive metastatic prostate cancer, I have several choices. I could certainly prescribe docetaxel chemotherapy, and that would be an option for patients with high-volume metastatic disease. However, in my practice, most patients are lower-volume metastatic disease, and therefore docetaxel chemotherapy is not indicated for patients with low-volume metastatic disease. So then, in that patient who has lower volume metastatic disease, or higher volume for that matter, we have choices including Xtandi, which is enzalutamide. We also could prescribe apalutamide, or we could prescribe abiraterone acetate. Abiraterone acetate has been around for a number of years, and that is widely used, but it also requires the administration of low-dose corticosteroids. And these patients who are otherwise healthy many times do not desire to have steroids added into their treatment regimen, nor is it necessary, and it could increase the side effects. So prescribing enzalutamide or Xtandi does not require the co-administration of steroids. It does not require liver function testing monitoring that would be required with abiraterone, and certainly it does not require the intensity of treatment that would be required with chemotherapy. And many urology patients who are satisfied or happy sticking with their urologist can do that with Xtandi because it's an oral agent. It can be easily prescribed by urologists. They do not have to be referred to a medical oncologist, and urology should be completely comfortable prescribing this agent now and in the future.